So far we have one question regarding to the heater you use. What's the name of the heater you use for the biogel?
Oh, that's a good question. I will tell you it's from Emsite. So the heater I purchased from Emsite, but I will tell you that it is available on Amazon. I would say maybe a little cheaper, but it's freely available. If you just look up PRP heater, you'll find one. But you can get one through Emsite as well.
So, okay, I have a couple of the question. Have you tried using the concentrated protein to make the biogel or not?
I have not.
Because the mechanism of this, you actually denature the proteins, mostly albumin, and then use that albumin for the scaffolding purpose.
Hmm.
So, but I was wondering if we could increase the concentration of the fibrinogen and then use the thicker uh, initial liquid instead of PPP, uh, would be more long lasting or not? I don't know, just as an idea. Maybe we could discuss later about this in the future.
Right. No, I totally agree with you. We are denaturing that. And the idea is that we're leaving the rich platelet plasma behind and then we're mixing it. But yes, we're taking the PPP and making it into a gel to kind of really for the volume. And I think, I'm doing PRF and biogel under the eye. Like PRF is great. And really it's for people that have like creepy skin, dark circles. But when we're doing the biogel, we're really getting that volume. So people that have volume loss, they're really seeing a better result with the biogel. But I would be open to, finding another way to make that gel without denaturing it.
We have another question. They ask, why do you use activator with biofilm or maybe biogel, they meant?
Biogel.
Uh,
Yeah.
and if you already have liquid gel PPP form. But yeah, go ahead for this.
Yeah, I mean, I use it so for the PRP because I'm microneedling that in, and I just feel like that's going to be enough to activate it. The biogel, because really I want to activate that, and I do that for anything that I'm actually injecting, right? So I do use the activator for PRF and biogel because I do feel like it just, starts to cascade faster, and I am mindful of my timing that I'm mixing it with the calcium chloride right before I'm injecting it into the under eye, and I've been doing that with PRF and biogel. But I can't really tell you that I haven't really done a lot without it. But from my, review of the literature and kind of randomized trials that I've seen, it looks like the results of doing a calcium chloride activator gives you better results.
So there is, I would say, probably its suggestion, get better feel with concentrated PPP. That's the suggestion I
Yeah.
also mentioned. Yeah, but there are a couple of the idea behind of that. And for the next webinar, definitely we are going to talk because so far in the society, we know the concentrated protein as A2M. We know it's famous as A2M product, but it's the only one protein in this product. There are more proteins collaboratively work with the A2M regarding to minimize the inflammation, and also there are some structural protein. We did some study about the amount of them, about the recovery of them, and in our next webinar, we are gonna bring some information you probably cannot find in the literature so far. Hopefully, we could publish those information as well. Another question, the concentrated version of the PPP with the concentrated will get you more volume and activated albumin rather than the natured protein post-healing. So I don't know if maybe it's the typo-activated albumin. It's different from the A2M. So two different things. But if we want to make the albumin denatured, we definitely need to increase the temperature. By increasing the temperature, we already denature all of the protein. That's why we need keep them at room temperature for immediate use, or if we want to use them later, it's better to keep them in the freezer. But albumin has different, I'm gonna answer to that question. Albumin
Okay.
has different function compared to the A2M. A2M is anti-protease inhibitor, and albumin is a kind of antimicrobial protein with the structural function, and also it could be helpful for some bone regeneration. And also, albumin is very good to increase the bio availability and bioactivity of the growth factors and other proteins. So in the drug delivery field, when we want to have the sustained release of the medications, albumin is one of the choice to encapsulate the medications to increase the bioactivity and bioavailability of them. So yeah, there is another question. I think both doctors mentioned that they use lidocaine as local anesthetic. I've heard that actually lidocaine, due to its pH, can deactivate PRP. Is it true? Dr. Linkoff, Dr. Shaw. The question actually, when
I
you use the lidocaine, it can affect on the property of the platelet and in general PRP.
Um, I don't think that that's absolutely true. First off, second of all, we use it on the periphery. So, like, if PRP isn't being injected here, the lidocaine is injected on the outside. It's not like injected everywhere. So, maybe there's a point where they're interacting, but for the most part, I think the PRP sort of overwhelms any lidocaine pH that's there. I don't think that's an absolute truth there.
agreed. And I use it topically. I don't inject lidocaine, but I use it topically and then take it off.
And
Yeah,
also,
it's pretty common to, yeah, either topical or injected. I don't think anyone's having major problems with that.
also there is recent publications, I think published in 23 or 24. They reported a certain concentration of the lidocaine. They checked different concentration, and I think 0.5 was safe, and it didn't affect on the platelet quality. Probably Dr. Paul could correct me if I'm wrong, but I guess it was 0.5 as I recall. Any other questions? So I could ask, let me see, we have another one.
Are you looking? I have a question for you, Dr. Linkoff. So
Uh,
yeah, because I do some hair
Sure.
PRP. So I
yes.
mean, I'll give you my sort of take on hair PRP. I have a lot of people that are not open to getting a transplant, are
Yeah.
pre-transplant or post-transplant. And
Yeah.
so my take on people that are coming to get hair PRP, and I think it's really important, as you mentioned, is
Yeah.
managing patient expectations. I
Yeah.
also feel that the treatment, and of course, I'm not an expert on hair, but that the treatment has to be multi-pronged, right? So the first thing that I talk to people is kind of what you just kind of went through. Like
Yeah.
this is the first tier, like minoxidil, finasteride,
Yeah.
spironolactone, etc.
Yeah. Yeah.
And I don't know if you're getting this, but I get a lot of people who don't want to take the pills, or they have, especially male patients, and have had terrible side effects. So they're refusing to take that. Then I go into the topical stuff like Rogaine, plated exosomes. I don't know how you feel about that. Um,
Mm-mm.
and then I go into obviously healthy diet, blah, blah, blah. And then third is PRP. So I guess my question to you is understanding that, it's not going to be like a 9-day difference, but what's your take or how do you approach somebody who's like, look,
Yeah.
I get it. Like I probably need a hair transplant, but I don't want to take medications. I'm not getting a transplant.
Yeah.
How do you feel about PRP then? That's one. And then two, how come you don't use a 30 cc kit?
I don't have a great answer for the second one. It's just like,
Okay.
you get like you get used
Okay.
to what you're ordering and then you just order it. Yeah, we just have the 20 and the 60. There's no great
Okay.
explanation for that. The 30 is the dual spin still, right? Like for the
Yeah, it
surgery,
is. It is.
we
That's
want
why
to
I was
yeah, for the surgeries, we just want to simplify our life because we're already there all day with the patient. So we feel like it's kind of good enough for like the purpose of the surgery. But as a standalone, we want to give people, I guess we could do two 60 cc syringes, but then it's like most people are not going to tolerate that. So we do as much as we think they're willing to put up with to try to maximize their results. So I guess that's maybe why we did those extremes. But yeah, to answer the first question, especially for male patients, we're just like tougher on them. We don't let them off the hook when they say, "Oh, I tried this finasteride and I got side effects." Okay, did you try it at a lower dose? Like, when did you last try it? How, we basically play with the dose of the finasteride. The other thing to realize is that finasteride at a standard dose, 1 milligram pill daily is effective in about 90 to 92% of guys with androgenetic loss. So there's all types of sort of misconceptions, but one is that if they're taking it, well, then it must be great because they're already taking this pill and like, what more can they do? But the truth is 8 to 10%, we need to bump up their dose and or switch them to dutasteride, which has at a standard dose about 98% control. So, I see it as like a continuum. You've got like, we've gone up to dutasteride 2.5 milligrams a day. That's like very extreme, and I don't know, 1 in 1,000 who maybe needs that. And then all the way on the other end of the spectrum would be like a topical finasteride, and we've gone down as low as like 0.1%. But the problem is at some point it's like or point like 0.05%, but then it's so weak that it's probably not going to do a whole lot. Like standard dose for topical finasteride is 0.25, 0.3 percent, and that's usually what we go with. But yeah, so um, and then you can go so strong on the topical finasteride. There's this one company, I think is Zion. They have a gel that's like 2.5% finasteride. If you apply enough of that stuff, like often enough, you'll actually suppress DHT beyond the 1 milligram pill. So I tell people just be careful. Like it's not just because it's
wow.
topical finasteride doesn't mean it's like safer or less likely to give you because this stuff is getting absorbed systemically. That's how it's working. And another misconception is that, oh, because you're putting it right here, it's just working right there. It's not true. So, so some people feel like, oh, topical, but it is true. Like generally at the standard topical finasteride dose, it's going to be weaker and people are going to tolerate it better. Is it going to protect their hair? I mean, maybe, maybe not. But for some people who've had side effects, so 1 milligram finasteride, they have side effects. We take them off. Usually symptoms resolve after a few weeks to a few months, but usually a few weeks. Then we resume at usually 1 milligram every 2 days. Then we go to every 3 days if they continue to have issues. Then we go to 0.5 milligram. And so we do like a gradual dose reduction. We don't just say if they have a true like allergic reaction, sure, but I've honestly never seen that. It's very rare for finasteride. So we just tell them, look, like, yes, at the maybe standard dose, you felt something. It was probably real. Like, we should wait for that to resolve. I've never seen side effects not resolve, contrary to some online forums. And at hair conferences, we're always talking to each other. Like, we do polls. Like, some people have been doing this stuff for 40 years. No one's seen a true post-finasteride syndrome patient ever. I think if you're being monitored and you have like an actual doctor, right, responsible for you and listening to you, like no one's going to tell you to just keep going if you say, oh, I'm having, decreased libido. So it just doesn't make sense that a pill that's metabolized and is required, every day is somehow going to, give you lifelong problems after you take it a few times. So yeah, so that's the way we approach it. We don't just say, okay, you can't do that, so now let's do all these other things that we know are not hitting the prevention bucket where they're still going to ultimately lose. And especially when we get into the surgical realm, because now they've paid, a lot of money for like a single thing, PRP, eventually they're spending a lot of money, but it's like a one time they've paid, they expect results, and then a year goes by. If like they have the new transplanted hair and the hair that you built on now pulls away or another whole area opens up, they're pissed and like it makes us look bad. I'm not happy, they're not happy. So I've become a lot more strict about almost like requiring finasteride unless I see years of stability that they can document. Either I've been seeing them for years or they can document in photos and they're a little older, like not usually even 20s and 30s, but like 40s plus. Maybe if it like hasn't changed in 5, 10 years, I might consider it. But it's like very tricky if it's a moving target. And the problem is there's a limited number and like it's not just like, oh yeah, we'll just do more surgery. The density distribution might make no sense, right? Because like if they're 25 and I built this area up with like almost 2,000 grafts for high density, and then they lose so much more hair, all of a sudden it doesn't make sense to have that density here. I have to like drop it down and it just kind of looks funny. Versus when someone has a more advanced pattern, and that's a much safer bet for surgery because I can make it look, better for their current state. So trickier with younger patients, but that's what it is. I don't like to deceive people. It's one thing I think a lot of people don't even understand this. Like a lot of dermatologists have no idea. They're giving people, minoxidil, top of Rogaine, just, oh, you have hair loss, stick on. Person's on Rogaine for years and they're still losing hair, but they're like, oh, but the doctor gave me this. So there's just a lot of misunderstandings, even amongst, physicians. Um, but like once you know it, then I just feel bad like not getting people on the right thing. Um, but yeah, that's the way I see it.
So we have a couple of questions now here, and one question I have for both of you. So have you tried to check the influence of the concentration of the platelets you are gonna deliver? So since now we are using 30 ml, 20 ml, and 60 ml, and the difference is gonna be the amount of the platelets. And also at the final volume, it depends if you use the 30 ml and you're gonna have 4 ml as your final volume, and for 60 ml, you're gonna have 8 ml. So your dose per ml should be a kind of similar regarding to the concentration, but the absolute number of the platelet you deliver is going to be different. I'm asking this question because in MSK, so we have that consensus for some specific indications, we need to deliver at least a certain number of the platelet. For example, for knee osteoarthritis, based on some clinical study, we need to deliver at least 10 billion or more to get long-lasting result, at least 12 months pain reduction and good result. But now, even the updated results in the uh, data collecting platforms and our doctors, when we are talking, they're using even more for 20 billion. They deliver 20 billion platelet for each joint, for big joints like the knee joints, or for soft tissue like tendon. We have that consensus. We need to deliver something over 3 billions, but the best one, something around 5 billion. But regarding to your practice, for aesthetic and for the hair. Do you have any at least a range, or I know we don't have any standard uh, for PRP application for so many specialties and field, The more advanced regarding to standardization is the MSK, since we are using cell counter in the MSK in our clinics. But regarding to your practice, based on your experience, if delivering high dose platelet is always good, or you check that it doesn't matter, or for some indications, even you prefer to deliver less platelets?
Maybe Dr. Shah, if you want to go first.
Okay, thanks. So I have no idea, right? So I don't have a cell counter. I know that there are ways that you can count and really know that how high of a platelet count you have in your PRP. The way I do it in my practice is I follow the standard protocol every time. So when I'm doing PRP for microneedling, PRF for injections or biogel, I try to keep the same volume and use the same volume every time. So in the way I look at it is that if I'm using a good PRP machine, I trust Emsight. I have two machines. I do it the same way every time. I have good results. For me, like it's different, I think, at MSK. I think for me, it's about my outcomes and I have good outcomes. And so for me, I think, is it so important whether I had, 4 billion versus 4.5 billion platelets, or is there an absolute number I'm looking for? I would say no, at least in aesthetics right now.
I agree. Every time I go to a hair conference, I'm always like trying to figure out like, should I include more of like a quantitative analysis? I'm always racking my brain and thinking about it and seeing how other people do things. And, but then I feel like a lot of times for aesthetics, there's that gestalt, the all these numbers, and maybe even in MSK, maybe for insurance purposes, the numbers matter. But at the end of the day, it's like, did their pain get better or did it not get better? Like I don't think the patient's going to care exactly how many billions. And maybe clinically, like you need a certain number for that pain to improve. But yeah, I agree. Like, I mean, that's why I use the 60 cc. Like, I don't know, what am I supposed to do? Use two of them if like I didn't get over a certain number of billion? Like, I thought about buying the cell counter at the last Global Aesthetic Conference, but then I was like, I couldn't justify the expense because I was like, I'm just going to be using it to not really for us, but for the patient to kind of see that we're being a little bit more, numerical, quantitative. And I think about that with hair surgery as well, because, sometimes people are calculating like, um, how many grafts did you place per centimeter squared? And I'm like, I don't count that. Like it doesn't change how I do the surgery. Like, yes, we count the number of grafts. We don't have an exact count of the number of hairs. Some people are counting, okay, we had, 952 hair grafts, 1,003 hair grafts. Like it doesn't change the quality of their outcome, in my opinion. So there's lots of people in the field who have beautiful results who do no counting. There's people who have beautiful results and they count. And then in the other categories too, there's people who count every little thing, and then you look at their outcomes and you're like, wow, like that, like how have they been doing this for 20 years and they haven't figured out how to make it look nice? Like, so it's not I don't know. It's not so black and white. And every time I think about incorporating numbers, like we bought that Tricolab thing, and honestly, it's mostly collecting dust. I mean, some patients are into it, and we're like, okay, yeah, we'll offer you numbers. But it's like the numbers, if the numbers are growing, but like they don't really see a change, then you're just trying to convince them that, they should keep paying for it when they probably shouldn't. So I don't know. That's the way I see it in a similar way. Like get a good system, trust that it's, that you have to know how to use it, and that, if overall patients are more or less content, and you stick with that. I mean, if you're doing actual clinical research and you're trying to write papers on which concentrate, then yeah, you have to look at numbers. But in a clinical practice, I haven't found that to be overly helpful in hair.
And another question.
And
Yeah, sure.
I'll just add one thing to that. And it's true. I feel like when patients come, at least in aesthetics and facial rejuvenation, they have no idea the type of machine I have, right? And I see like in the world of aesthetics and what people are using for their PRP machine, and I will tell you is not high quality. And the patients have no idea where I have to be like, well, we have M-Sites, one of the best machines, the best platelet recovery. Really, they have no idea. And so I have to tell them like how great a machine I have and the platelets and why it matters. And nobody really is coming to me and saying like, hey, how many platelets? How do you know? Like never. So I think Dr. Linkoff is absolutely correct. I think you go by your outcomes, patient satisfaction, and kind of like, you have the best machine and you trust it. And that's exactly how I feel too.
Yeah,
So
and one more thing, sorry, just to piggyback on
sure.
that, like it's the practicality of it too, right? Because like we run busy clinical practices, it's like if there's this extra step, and you multiply that by like lots of patients, eventually it adds up, so if every time we got to put something extra cassette and this counter and wait and look at the numbers and explain the numbers to the patients, it's like, it's a lot of extra work that maybe comes back to benefit you, or maybe you just wasted a lot more time.
So let me disagree with this at this point because I believe that, and we believe that. So it's not just the number, since we have other components now. We have had all the time, but now we are considering other components beyond the platelet, and we know they are playing the role, specifically monocyte. Uh, in the leukocyte family and neutrophil. In MSK, so we have better data, and at least we have some couple of ongoing projects to uh, finalize that debate about the leukocyte poor, leukocyte rich, which is now mostly neutrophil poor, neutrophil rich, monocyte poor, because we definitely know some cells like monocyte can change, can be a big play, a big game changer in the outcome. And also, I brought an example for two different pathology, and in one TGF beta could be very helpful, in another one could be even detrimental. So something like this, we prefer to characterize the PRP to make sure if we include leukocyte, for example, it could be helpful or not. If we go for higher concentration, we could increase the growth factors, but that growth factor could be helpful or not. For example, for a hypertrophic scar, uh, I usually recommend for most of the indications high number of the platelets, high uh, dose of the platelet, but for hypertrophic scar, I don't. I prefer low number of the platelet and combine the platelet PRP with another modalities, specifically stem cells, to change the game, because in that case, high concentration of the TGF beta, so could be detrimental. And we need just TGF beta to start something, but we don't need that much TGF beta. We need mostly BMP molecules to start some dedifferentiation of the myofibroblast toward the adipose cells. And there is
Yeah,
uh,
but I'm sorry, but do you guys have protocols for this stuff? Like exactly how much of
so
each thing is needed?
For MSK, we are working with our doctors to develop the protocol for different indications. Mostly, we have some agreement for some indications. Okay, for that indication, we prefer to have leukocyte poor or neutrophil poor. We don't want to include the neutrophil because it's going to be like putting a gas on a fire. But
Mhm.
for some other indications, when we need more angiogenesis, we probably prefer to include the leukocyte, even neutrophil, to increase the possibility of the angiogenesis.
And how do you separate out that? How do you separate out the those elements?
So that's the key of the MSite kit. With the new design, we have that possibility and flexibility to selectively include the leukocyte in the PRP bioformulation or not. I watched the movie of Dr. Shah. So she's using mostly leukocyte pore as a gold PRP. But sometimes we have a kind of pinkish PRP, which is the PRP with a little red blood cells, but we define that based on the recovery percentage of the leukocyte. We define that if we want monocyte reach, we need to take this amount of the red blood cells after the Buffy code. And with this protocol, we are going to have, for example, over 90% monocyte recovered, but less than 10% neutrophil. And for some indication, it's going to be the best compared to the leukocyte poor or neutrophil rich. Or if we want to have neutrophil rich, we prefer to take more red blood cells, for example, 1 ml in the 60 ml kit to include the highest monocyte, highest percentage of the lymphocyte, and also certain percentage of the neutrophil. We already have the protocol for different bioformulation at MSite, but it depends to the indication you are going to use. My question was, if you tried for different pathology, different bioformulation, or you are just using the same bioformulation, even if we put the number now away, we don't want to talk about number.
I mean, I don't know where to find these recommendations from MSite on which one would be the preferred one for hair loss, for example. Like where
That's my question, because we have the protocol for preparation, but for indications, we have some evidence from the basic science, and then we are asking the clinicians to do some research or based on their experience.
No one's asked me yet, so
okay, we can have
I'm
a
just saying,
yeah,
I haven't done it because no one's come up with that idea, and I haven't really thought to investigate that specifically myself. So I'm open to it, but yeah, I mean, until there's like a defined protocol, I think it's reasonable to do the standard. But on the flip side, it's always nice to investigate something new.
Yeah, because today I was reading the Nobel Prize in the medicine this year. One of the topic was lymphocyte in the regenerative medicine in the cancer field.
T
So
cells.
T cells. So
Yeah.
and we know the Treg is one of the key player now in regenerative medicine. So why we don't want to consider that and include that? This is my point, but that's good. We could have this conversation later for a couple of the study together. We have two more questions. One of the question is, have you tried stem cells, specifically bone marrow concentration, BMAC, instead of PRP for hair the restoration or hair transplantation?
The patient's own bone marrow?
Yes.
I don't know who's doing those types of investigations. I don't even know. You'd have to do a bone marrow biopsy, or what are we talking about here?
Probably you need to use the needle and aspirate from iliac crest. So it's going to be very painful. So
The
definitely.
answer is no. I don't know anyone doing that on a routine basis, or even a study for that. I'm not sure how practical that is, honestly. But some people are doing like adipose stem cells. So I've done that on occasion to prep the scalp leading up to a transplant. In the case of like certain scarring alopecias, where I'm trying to like prepare the area, and especially if they've had a failed transplant in the past. So that's a very kind of uncommon indication, but we've done that, but not like some people do it a little bit more routinely. They incorporate like a fat harvest and fat transfer to the scalp, but I'll only use it in very specific cases. But yeah, that's stem cells, and Um, you could do the nano fat without the actual stem cells if you're not looking for like volume. They still have you know, so you get, I think, the stem cells, but you don't get the actual fat cells. So if you're not looking to bring in volume, you could do nano fat and still get the fat stem cells, like purified.
That's perfect. So one question, when you are doing PRP injection and applying topically with microneedling to build collagen, to reduce the fine lines and enhance the appearance, do you place patient on collagen supplement as well? If so, what types of the collagen should they take?
So I don't. There's some data, but limited data. But a lot of people are taking collagen supplements, usually like in a protein, like powder sort of format. So I don't put anybody on collagen supplements, but I don't think there's anything bad with them. I just don't think the data is strong. But there's some people that swear by them. There's so many different kinds. I think the most tolerable are usually the protein powders that people put into their drinks.
And another doctor asked a question from Dr. Linkov about how do you prepare your nanofat?
I added the link there.
Okay, yeah.
It's Tulip Medical. They have really good products for fat transfer. And basically, you just have to go down in size of the particles. And then eventually you arrive at nanofat. It's just more liquidy.
Have you tried Progenicon, the fat kit of the M side? Because we have the fat kit to harvest the fat and
Oh.
make the microfat. So we have collaboration with Tulip because we don't produce the filter of the nanofat, but our system for fat graft and preparation of the fat, very, very high quality and very clean. You're going to have very clean fat.
Okay.
Yes.
Haven't yet. I haven't yet. I don't do it too often. And then I think same person asked about the injection. So yeah, I mean cannula. I like to use a cannula for the nanofat, but not for PRP. PRP 25 gauge needles. Nanofat usually cannula.
Okay. And we had another question here. Let me check.
I want to know it all. Usually like 25.
What size of cannula? Yeah.
Yeah, 20. I think it's like maybe 21, 23, 21, 23 gauge. Yeah, 25 gauge, I think is, yeah, that's the needle. And then the cannula that goes into it, I think is like 21 or 23, something like that.
Okay. Yeah, the recommendation for cell counter is the M-side Reginostat. That's the point of care. So there is a cartridge. You could drop one droplet of the blood before preparation of the PRP, and then after preparation of the PRP, another one, insert the cartridge, and it calculates and it measure everything and gives you the number regarding the platelet recovery, baseline of the platelet, white blood cells, and it's kind of CBC differentiation and also the percentage of the hematocrit. It's very straightforward, very cool machine. So I don't see any. Okay. Dr. Paul asked, have you tried laser with your PRP? So he's actually using class 4 laser for MSK practice, but for your practice, have you tried PRP with laser?
Laser for hair, so like the Luminous Folix, that they have an approved laser, that type of laser. I don't know which wavelength they
This
use.
is a class 4, I think. Dr. Paul, please help me if you are here. Um,
Or Folix.
I think it has two different wavelengths.
1565 is Folix. The short answer is no. They reached out to me to help them with their clinical study when they had just mouse studies originally, and I looked at them, and they had some very early clinical pictures from someone who had kind of tested it in Europe, and I was just so underwhelmed by the clinical outcomes that I was not interested in really working on it. That's my takeaway from Folix from Alma TED. That's more an ultrasound technology that's been approved also for hair stimulation. I'm just rarely impressed by the outcomes that I see. You know, you got to understand, like when we do surgery, like the differential can be so ginormous that like that's kind of what I'm used to seeing. So when I see, you know, medical outcomes and even from finasteride minoxidil, we see sometimes very impressive results. So like that's the bar in my mind. And like it's very hard to find anything that can kind of get there, including all these like fancy new machines. So if I'm gonna, you know, I'm in New York City, it's a kind of a smaller space. You know, if I'm gonna invest hundreds of thousands of dollars, I'm actually working on building my own tech for hair transplant surgery from a patient-centric perspective, not just like to make something new, to advance the field surgically. So if I'm going to spend hundreds of thousands of dollars on someone else's machine, it's got to really like be something very special, not just for me to use for marketing. I mean, luckily I have a platform to educate people, so they already trust me. I don't need to say I have some new fancy device. Um, that's honestly how I see it. So I have not been impressed by the Folix outcomes.
And would you recommend ring block versus a scalp block, or both equal depending on comfort level?
What do they mean by a scalp block? Because when I'm talking about a ring block, it's on the scalp. So I don't know what they mean by a scalp block. I think we're probably talking about the same thing. The ring block indicates like a ring around the scalp. So if you're doing the frontal scalp, for example, the ring is not a full ring around because we know, you know, the nerves come in and you'll block pretty much up to the vertex with a frontal block. So then it's like almost like half a ring block. If you need to capture the crown mid-scalp, then you're going kind of a full ring, but it's the scalp. So
They mention some block the frontal and some occipital.
oh, yeah. I mean, you can do a more occipital nerve block, but it's usually not something I specifically try to target. Like, yeah, there's like, you know, landmarks for exit. I don't do that for surgery or for, it's just, I don't think necessary. You can, but sometimes it can be hard to find the exact kind of exit. And then as far as V1 blocks, you know, supraorbital, supratrochlear blocks, I sometimes will employ them for surgery, but maybe in like one every 50 patients when they're very, very sensitive and we're, you know, but we're stabbing their scalp a million times with, you know, needles and stuff. So then we'll do it. But for PRP, I don't think we've ever needed to do one. I don't know. It's briefer, even if they feel a little bit, they can kind of get through it when when I'm, you know, spending hours and hours on the area. And also the bleeding can be a problem for us as we're using, you know, something bigger than a 25 gauge needle for the site making to get the grafts in. So the bleeding, even if they're not too bothered by it, if there's a ton of bleeding, sometimes I'll do a block here. But it's a pretty delicate, painful area, so I try to avoid that block if at all possible.
Oh, and let me check if we don't have any. And I have a recommendation. So have you tried concentrated protein for your practice? Since basically because of the protein like albumin and fibrinogen and also fibronectin, it could help to make better ECM when you transplant the follicle. It could make better and stronger placement for them. So
Maybe, yeah, I've never tried that. Not yet. Not yet.
so yeah, we have a couple of idea too.
Yeah. I'm always open to new things. Absolutely.
Perfect. So, okay, so far we don't have any other questions. That means we could wrap up early. Perfect. Thank you so much, Dr. Linkov and Dr. Shaw, for taking your time. It was very, very informative for me, and I learned a lot. And I hope we could have this conversation going and improve the information and knowledge in this society together. And thank you all of the audience. You took your time and stayed with us. And again, we are going to have another webinar on the December 4th. It's going to be the last Pearly webinar in 2025. And the last one, we are going to talk about the concentrated protein, which is famous as A2M in the society, but it's not just A2M. And we are going to talk about other players beyond the A2M. Stay tuned. You will receive the invitation link very soon. And we are going to share lots of new information, even you cannot find in the literature now, but all of them based on the experiments and based on the evidence we discovered in our lab and based on the basic science and rationale behind of different protein and signaling pathway of the different protein they could provide for us for our purpose. Again, thank you so much. We will see you soon on December 4th. Thank you, Dr. Shah, Dr. Linkov. You have wonderful night.
Thank you. You too, guys.
Thank you,
Thank you, everyone.
everyone. Have a good night.
Good night.
Thank you for joining us in this session of EMSITE's webinar series. Stay tuned for our next episode as we continue uncovering the science behind precision biologics.